Hello, good morning, and welcome to the encore presentation of our webcast for reducing hospital readmissions. This is Lucy Savitz at Intermountain Healthcare, and we're happy that you could join us this morning. Next slide, please. Next slide, please. While I'm waiting for the next slide to come up, let me just go ahead and do a couple of quick reminders. One, we sent out a June quarterly survey, and in these quarterly surveys that we send to the key contact at your hospitals, we're trying to solicit important input from the hospitals that we're working with across the country. For example, we're asking for the contact information, email addresses for those people who are interested in the various affinity groups, and we'll use that to stay in contact with you. There are about 20 of our 115 hospitals that have not completed the survey, and we are doing follow-up work, so if you could please work with your key contact at your facility to complete those, we would really appreciate it. The next webinar will be on August 6th, and the topic will be on pressure injuries, and Marlene Conti is our subject matter expert who will be leading that. We also have affinity groups that we've set up, and this is actually an important opportunity. These are voluntary calls, they're open, and it's an opportunity for you to ask questions of the subject matter experts. So we had one on patient falls and immobility on July 13th that went extremely well. There was a lot of good interchange, not just with the subject matter experts, but across hospitals that are working on the same problems. And then we have one later this morning at 10 a.m. Mountain Time on early elective inductions. So we're very excited about that. The next one on OB topic area will be on August 9th at 2 p.m. And just a reminder that if you need technical assistance, have questions, or have any other kinds of requests for information, please feel free to email us at admin@henlearner.org. And then for resources, a calendar of events, and any archive materials, including the webcasts that you can make available to your staff who are unavailable at these times for the live webinars, you can go to www.henlearner.org. Next slide, please. So just a reminder, I'd like to be sure that everybody's aware of the common goals that all HENs are working on. Our request from CMMI is to reduce hospital-acquired conditions by 40% by the end of 2013 and to reduce unnecessary readmissions to the hospital by 20% by the end of 2013. Next slide, please. Those are audacious goals that focus on these areas, and the first three that are bolded are what CMS is calling our first focus areas. The obstetrical trauma with a focus on reduction of unnecessary early inductions prior to 39 weeks is also part of the Strong Start initiative, and some of you may be applying for those grant funds. And we've been blogging about the updates on access to those funds, the webinars to support your applications. I will also say that CMS, because of their interest and the importance of this, is making a contract modification to our HEN contract, and we'll be able to make the payments now in August to those hospitals that have committed to be active learners, to actively work on this and submit measurement data around EED. And we will be contacting your hospitals in the next week to begin to make those payments. The other two areas are, one, patient falls and immobility, and this is one that the hospital selected in response to the surveys that we sent out in March. And then lastly, preventable readmissions, and again, that's the topic of today's session. Next slide, please. So with that, I'm going to turn it over to our actually, before I do that, let me just say that this is a link to a success story from McKay Hospital, which is located in Ogden, Utah, and you can go there and take a look at one hospital's experience. This is actually an Intermountain hospital, so it's there for you to share with people that you work with. One of the things we try to do with the success stories, and you'll start to see those in the newsletter that's coming out, from all of the hospitals, and we ask you about those in the quarterly surveys so that we can follow up with you, is to show what's possible in different kinds of facilities that are struggling with these exact same issues. Next slide, please. So again, with that, I'd like to turn it over to our subject matter experts. Our first subject matter expert who's going to speak with you today is the lead in this area, Dr. Andy Masica from Baylor Healthcare System. Andy?
Okay, thank you for the introduction, Lucy. Thank you for the participants in today's webinar. Again, as you can tell by the title, really what I'm hoping to do today is frame up a reduction to the issue of reducing hospital readmissions. It's a complex problem that requires a multifaceted intervention to show improvement, and we view this webinar as a starting point for the improvement efforts. Next slide, please. The presenters on this webinar have no financial interest in its content. Next slide. This is the requisite CME statement. Next slide, please. As Lucy mentioned, I'm Dr. Andrew Masica. I'm with Baylor Healthcare System. I'm the Vice President for Clinical Innovation. My co-presenter today will be Dr. Brett Stauffer. On the bottom of the slide, there's some information about Baylor. Just to clarify, we are Baylor Healthcare System in Dallas, and in spite of the name, we do not really have an affiliation with the Baylor College of Medicine, which is in Houston, or the undergraduate campus, which is about an hour and a half south of here in Waco, Texas. Next slide, please. With the first version of the webinar and also working with us as a subject matter expert is Dr. Doug Koekkoek. He's the Chief Medical Officer at Providence Health and Services. He could not join us today, but again, on the bottom of the slide, you see more information about Providence. Next slide, please. So the areas that we're going to cover today are fourfold. First, we're going to talk about the importance of readmissions in the current healthcare environment. Why is this a problem that people are interested in? Next, we're going to discuss metrics for performance improvement in the area of hospital readmissions. We're going to talk about how to develop intervention strategies to reduce readmissions. And then we're going to identify and point you in the direction of some resources to start or extend our readmissions reduction program. Next slide. So this I think is a good, those of you who are familiar with Gary Larson, the creator of the Far Side cartoons, I always like to show this when you're talking about unintended consequences. In modern medicine has become very good at acute care. One unintended consequence of that is we have created patients or a population of patients with complex medical issues and many comorbidities who are at high risk for readmissions. And so that is the challenge that we face in some parts due to our success in other areas. So with that, I'm going to turn this over to my colleague, Dr. Brett Stauffer. He's going to frame up the scope of the problem for us. Next slide.
Thank you, Andrew. And I'll just jump right in. A lot of you may be familiar with this paper by Jenks that was published in New England Journal of Medicine that sort of provided the epidemiology of readmission and gave us an idea of the scope of the problem. And this table is adapted from one of the figures in that paper. The main thing I want to take from this, and you can go back and look at this in more detail or look at the paper to get a broader perspective, but some of the takeaways that I wanted to portray here is one, that we tend to think of this as a medicine problem, and it certainly is, and we often think of heart failure as being the prototypic readmission diagnosis, and it certainly is the largest contributor and is why I think a lot of people have studied it to start with. But the problem is much broader than that. It includes many different types of medicine diagnoses. But in addition, many surgical procedures also have a high readmission rate, 30 days out. And that actually accounts for almost a quarter of all of the 30-day readmissions. And so this problem, while a lot of people I think have previously characterized it as just being a problem of chronic disease, specifically heart failure, it actually covers a much broader area. And as we gain more experience around it, I think the view is going to be that it's a problem in all of these areas. Next slide, please. So the question is why is this now becoming an issue. That paper by Jinks was only published in 2009, but this had slowly been building in recognition that this was a problem. Prior to that, the first reason is that it's costly. About $17.4 billion in hospital payments were made from Medicare in 2004 alone. And there's a substantial impact to all of these readmissions. In some hospitals, 25% of all readmissions, or correction, 25% of all admissions are actually readmissions from a prior hospitalization. And readmissions are a major source of patient and family stress. Most patients feel like they have gotten better when they're ready to leave the hospital, and obviously coming back seems like a setback and is disruptive to their progression and getting better. Most importantly, why I think it's getting more attention is that it's remediable. The Commonwealth Fund reported from 2006 estimated that if national readmission rates mirrored top-performing regions, the savings to Medicare would be about $1.9 billion a year. And since this time, there's been sort of more evidence accumulating that high-performing systems that do things well are able to reduce the readmission rate. Probably never to zero, as there are legitimate reasons why patients need to come back to the hospital. But there is the ability to have a big impact. Next slide. And to that end, readmissions are often preventable. There's traceable causes of avoidable readmission have been established. There's the reduction in hospital-acquired infection or other complication. In some cases, patients were discharged prematurely. Others, there was a failure to coordinate or reconcile their medications, inadequate communication, or poor planning for care transitions. And given that interventions exist to reduce their occurrence, readmissions are increasingly being seen as a measure of hospital quality. Next slide, please. As we kind of mentioned from that first table, readmissions affect all stakeholders. So Jinks, in his paper, along with others, looked largely at the Medicare population. That was the data set they used. And that's probably been where most of the focus has been. But while Medicare patients are at an increased risk for readmission, patients aged 18 to 64 have a readmission rate only 20% less than that of patients over 65. And rehospitalization rate is only weakly related to age. So this is going to become a bigger issue with private insurers and just in general other stakeholders who are going to want to see high performance in reducing readmission for many different patient populations. And to that end, readmissions are a problem for the entire spectrum of patients and payers, and an issue that providers will increasingly be held accountable for, either through CMS reimbursement or through ACO care delivery models. Next slide, please. So the question becomes, well, how do you make an impact here? And as the count will tell you, one of the first ways is to get a good measurement about what's going on with the problem. Next slide, please. So one of the roles of the Hospital Engagement Network is to help different facilities dive into these problems and get a handle on what's going on. And one of the best ways to do that is by having a metric that we can measure and track. Our recommendations for outcome measures are the first being an overall inpatient 30-day readmission rate. A sort of all-cause, all-payer is being advocated for all of the Hospital Engagement Network facilities. The idea here being that, as we've talked about before, it's becoming a recognized problem in many different areas, and the goal needs to be to try and reduce readmission across the spectrum of patients that are served by our different facilities. Additional outcome measures may be Medicare inpatient 30-day hospital readmission rate. And the reason you may want to do that is because the population characteristics for the Medicare population is sometimes different from the privately insured. So, you know, for a lot of the Medicare patients, there's an increased comorbidity burden, and so some of the interventions may be around managing the other comorbidities, whereas for other patients it may be simply improved management of the principal diagnosis to prevent readmission. Finally, you could have a third measure that was heart failure inpatient 30-day hospital readmission rate. Again, heart failure sort of being the prototypic one. It's one of the 3 metrics used as a basis for the FY13 CMS hospital payment adjustments, and it is a measure by which hospitals' quality is measured today. And so learning how to track that and impact it could benefit hospitals in many other ways. Next slide, please. So to get an idea of the level of detail we're talking, this is some of the characteristics of a metric that was excerpted from the NQF draft technical report, and it's the National Quality Forum's endorsed all-cause readmission metric. And the description gives you an idea of what they're going for. The key statements that I think are important for facilities when they're trying to recreate this locally is keeping in mind the numerator statement and the denominator statement. And in the numerator statement, basically what you're trying to capture is the outcome that we're interested in. And the key here is unplanned all-cause 30-day readmission. So trying to identify those readmissions which were not planned. So if you left the hospital and were coming back in 2 weeks for another round of chemo, that would not be a hospitalization you would want to count in the numerator because that was scheduled. It was actually anticipated as part of your care. What we're trying to reduce is the unplanned and unexpected readmissions. Same with the denominator statement, making sure that the population that we are looking at is correct. Looking at all-cause readmission for patients aged 18 or older is the broad goal, but as we mentioned, it may be that you want to limit that to patients 65 and older or Medicare patients. You could further characterize that patient population by specific diagnosis. The full version of this is available on the HEN website, and we'll give you a better idea of how these measures are constructed. Next slide, please. So the additional readmission metrics, as we kind of mentioned, the key is tailoring the numerators and denominators according to the group of interest. So why would you do this? Well, one of those is there's variation in the readmission risk across different inpatient populations, and having a specific metric would facilitate tracking of different intervention effects. So for instance, you might have a specific program that's targeting heart failure patients over the age of 65, and that intervention may work well for that population, but it may or may not have an overwhelming impact on a broader metric of, say, all-cause readmission for the entire hospital. And so making gains in reducing readmissions for that metric may require a combination of different interventions. Similarly, for Medicare, even if you select that as your denominator population, there are other questions such as, are we looking only at the patients where Medicare is the primary payer, or do we include those that have supplemental insurance, and how do you manage dual eligibles? Again, you could include them, saying that they all have Medicare of some sort, and so they need to be lumped together. In other cases, it may be that the dual eligibles require, a more refined intervention, and you may want to track that with a separate metric. And lastly, obviously, having a heart failure inpatient 30-day hospital readmission rate may narrow the population of interest even further. Next slide, please. In addition to having outcome measures, There is also an interest in making sure that we have a process measure to try and keep track of what is happening, just in case we don't see a change in the outcome. One of the first steps is making sure we're doing the right things that we think will have an impact on the outcome. And the process measure we're recommending is a measurement of what we're calling a transitional care bundle. And you could measure this either through the individual components or through some sort of composite metric. The details of the different individual elements Andrew's going to go into in more detail, but as a general overview, they could be sort of lumped into patient and caregiver education, medication management, transitional care planning and handoffs, and post-discharge contact. And the goal would be in this process measure to try and hit hopefully all of those with each discharge to prevent readmission, or at least focusing on one and trying to track how effectively that is disseminated for all the patients who are discharged, and then measuring the outcome metric to see how much of a difference we are making in reducing readmission. Next slide, please. So now I'm going to hand it back to Andrew, and he'll give you some more details.
Okay, great. Well, thank you, Brett. We've discussed why readmissions is a current priority, and Brett has given us some background on different metrics to assess baseline performance and progress. The next phase is to move into interventional strategies. So we know we have readmission rates that are higher than we'd like to see. How do we start to reduce that readmission rate? The cartoon is a tribute both to Greek mythology. We hope this is not a futile task, reducing readmissions, and summer vacation as well. So next slide, please. So something that's very important, and this will be a recurring theme throughout the remainder of the presentation, is that any interventional strategies need to be multifaceted. Programs that have a singular method of an intervention, particularly those that lack a community outreach component and are entirely hospital-based, are not consistently effective in reducing readmission rates. Evidence for that is in the literature. We have had some observed successes with interdisciplinary approaches used in SHM's Project Boost. Another effort that's similar to Project Boost called Project Red, that is re-engineering the hospital discharge. And again, they have had multiple switches that have been flipped to drive the reduction in readmission rates with those programs. I think another issue that's very important is in an era of limited resources, these interventional strategies do have costs associated with them. It would be nice if we had a very robust model that could tell us which patients were at the highest risk of readmission. Unfortunately, there are not any robust and good models that have been shown to be effective in a general hospital population. There was a recent review article referenced below in JAMA that looked at the different models. Now, what you may have are some models that work in subgroups. So for congestive heart failure patients, for instance, there are models that do have reasonable predictive power. You measure that by something called the C statistic. The C statistic for those models is sort of 0.7, 0.75 range, which is reasonable. But again, for a general hospital population, we don't have anything that performs particularly well. That's an active area of research, and with the dawn of the electronic health record and access to more variables that could be put into a predictive model, that may be changing in the next few years, but right now we don't have anything that we could apply readily. Next slide. I think a good way to think about readmissions and how to reduce them is to think of different sites of care delivery. The key, as mentioned, is multidisciplinary intervention. That has to happen in a care continuum process. This was a very nice review article that was in Annals of Internal Medicine last year, and it provided a taxonomy for the different types of interventions according to the point of care delivery. So in the hospital, patient education, and discharge planning, medication reconciliation, and scheduling a follow-up appointment before discharge. Our interventions can be readily delivered. You have the transitional care piece with a transition coach. That could be either your healthcare provider. Some models use a community outreach worker to do that sort of thing. Patient-centered discharge instructions, so discharge instructions that are meaningful and interpretable to the patient, not just checkbox type of things. And then continuity, including transfer of information between providers. Following the discharge, some important components are timely follow-up, usually within a matter of 2 weeks, sometimes sooner than that, depending on the complexity of the patient. Good communication to the primary care physician. A very popular intervention has been follow-up telephone calls, but again, as a singular intervention, those are not going to be effective if you don't have the other pieces in place. Patient hotlines, and then some models, as mentioned before, including home visits by care providers, have also shown to be effective. The Mary Naylor model is one of the ones that you'll see used commonly, and later on we have an example of how we applied that model in a Baylor congestive heart failure program. Next slide. I think the other critical aspect of any performance improvement effort is data tracking and then feedback and reporting of performance. As mentioned, one of the things that we're going to try and develop as a part of this HEN is a process measure that we can track. That provides an opportunity for a concept that we call measurevention. Measurevention is something that if you find that there's a defect in something, you're able to intervene on it quickly. And that provides benefit for the patient while they're still in the hospital. One of the pushbacks on certain process performance measures is that if you get a report about something that happened 6 months ago, it's not particularly meaningful to you in terms of changing your behavior as a provider, nor does it help the patient who had that process missed. So again, what you want to try and do is build a process measure that can be corrected while the patient is still in the hospital. Then looking at the outcome measurement performance, a key aspect of that is the data collection and transfer. There will be some mandatory reporting through Medicare and other groups that's underlying that entire process of reporting. You need these, the data and information to be timely, credible, sustainable, and you want people to be able to act on it. I think the other thing that's important is you have multiple stakeholder groups. Reports just to physicians or just to one isolated group of caregivers isn't going to be particularly helpful. You need to look at this across the spectrum of the hospital episode and who's delivering care and who's in a position to make the changes. Again, that requires an interdisciplinary group. Next slide, please. So the next few slides originally were presented by Dr. Koekkoek. These are going to reflect, I'm filling in today, these are going to reflect application of some of these interventional strategies at Providence Health and Services and their experience there. Again, they prioritize using a multifaceted approach, and what we're going to cover in the next few slides regarding the Providence experience are the concepts of pre-discharge preparation and education of the patient, the importance of timely or early follow-up appointments, the role of end-of-life discussions, unique challenges associated with caring for the SNF discharges, how Providence reported performance to their clinicians, and then also what the tactics that they use to get started on specific interventions. Next slide, please. So one of the things that we can do in the hospital is prepare the patient as well as possible for their post-hospital care. Most patients do not end up as readmissions. The patients who do get readmitted are typically the ones who are complicated with multiple comorbid conditions, often in a spiral of declining health. For those types of complex patients, it's very important to have a rigorous case management with a wraparound type of approach. Education of the patient, and this also, when I say patient, that also includes the caregivers and family members or anyone else who would be involved in that patient's care for readmission reduction programs. I think the key elements of education focus on medication list understanding and management, disease state education, and then getting them connected to the necessary follow-up, including primary care and any subspecialist physicians. A nursing or case manager discharge checklist is a useful way to track whether this education is occurring and could be part of that process measure that is developed. Printed handouts and a teach-back method to make sure that the patients and the caregivers understand the most important aspects of their care plan. And with that, you have to pay attention to cultural and language differences. Post-discharge phone calls are another option in terms of education. What they are particularly useful for are to ensure that medications were dispensed, that follow-up appointments were made, and looking for any early problems that could be intervened on without requiring a readmission or an emergency department visit. As noted previously, all of this is very resource intensive, so there's an ongoing need for risk stratification tools to target which patients need these types of resources. Next slide, please. Timely follow-up. Providence did a retrospective chart review with independent physician reviewers, and that indicated that in their estimates, up to a third of the readmissions could have been prevented with earlier follow-up to an outpatient care provider. 30% of the Providence readmissions occurred by post-discharge day 3, and 50% occurred by post-discharge day 7. So again, sort of the standard follow-up that you'll see in a discharge summary is, quote, follow-up with your primary care physician 2 to 3 weeks, period, quote. That may be okay for some patients. For other patients, you need a much more timely follow-up, and the goal should be 3 to 5 days. In most health systems using hospitalists, trying to get that 3 to 5 day follow-up requires a coordinated effort between the discharging hospitalist provider and the primary care provider. So the inpatient provider needs to know that the timely follow-up is necessary. There also needs to be access on the back end in terms of open slots to fill those clinic dates. Again, just talking about this on the hospital side isn't enough. You need that connection to the primary care groups. Next slide, please. So Providence also took a look at the timing of the handoffs to the primary care providers. They looked at the performance of some of their discharging hospitalists on how often they recommended the 3 to day 5 closer follow-up in their discharge summaries compared with a historical standard of 2 to 3 weeks. If you look at the run chart, over time, it shows that it took the better part of 6 months to make the change where the discharge providers were recommending that close follow-up within that shorter time window of 3 to 5 days. Providence also tracks primary care follow-up access to make sure that the other end of the equation is going to work as well, and that's access to the primary care appointments. Next slide, please. Another part of the Providence strategy is open communication about end-of-life care issues. Palliative care, which again, people think is probably best thought of as improving the focus on the quality of life, including symptom control and management. The challenge here is that these are difficult and time-consuming conversations, but they're a key component of any readmission reduction strategy. Many times when patients have 4 or 5 very difficult comorbidities that are end stage, the care can be perfect, but just their physiologic status and their disease burden makes it nearly impossible to keep them out of the hospital. That's where the end-of-life and palliative care discussions can have a major impact. Providence noted that 1/3 of the readmissions had unresolved end-of-life issues at the time of hospital discharge. They instituted programs to incorporate skills in conducting those types of end-of-life discussions amongst their hospitalists. They committed more resources to a palliative care consult program. And they also had an initiative within their primary care group to ensure that code discussions and those end-of-life type of talks had actually happened in an outpatient setting before the patient arrived at the hospital. And we also do that within the Baylor healthcare system. And I think that's a crucial aspect of these end-of-life discussions. It's very difficult for them to ensue particularly for hospitalists that may have no type of relationship with the patient or the family. So again, working on that on the primary care side is an important aspect. Next slide, please. The other area that represented an opportunity for improvement was the patients who were discharged to skilled nursing facilities. Providence observed that a quarter of the readmissions came from skilled nursing facilities. Follow-up of those patients was found to be inconsistent and many times occurred by phone and was not performed in a timely fashion. Providence thus looked at resources to implement a SNF rounding program. That program constituted a virtual team of physicians and geriatric trained nurse practitioners to round in the skilled care facilities following the patient's hospital discharge. They concentrated on facilities that had high readmission rates and a willingness to have an open partnership with those skilled care facilities to be committed to tracking performance. The skilled nursing facility providers continued the discharge education process, the end-of-life care discussions, and they also monitor closely for any type of an early decline that could be intervened upon before an ED admission or rehospitalization that would be required. So an example of that would be a congestive heart failure patient that needed a minor adjustment in their Lasix rather than letting it progress for a couple of days and then require full hospital admission. Current reimbursement of nursing home patients is insufficient to make this a profitable line of business. The environment that this type of program would work in would be an accountable care model or a Medicare Advantage plan. Next slide, please. This shows the feedback reporting that Providence uses to give to their clinicians. As mentioned previously, the reports and the feedback are very necessary to change behavior and create a culture to influence readmission performance. The run chart that we have here is updated weekly and posted in the Providence Hospitalist workrooms. It shows how many admissions have occurred each week. In addition, individual discharging physicians need to be made aware of each patient they discharged that had a readmission episode. Likewise, the primary care groups are also notified of their readmission rates. So the point there is that it's a continuum of care. The problems arise when you have siloed approaches where you have strictly hospital group and a strictly primary care group. You need those two entities to work together. Whenever possible, these reports are shown in a blinded fashion to stir the competitive nature of physicians. That can be a very effective way to change behavior. Next slide, please. This slide here represents the Providence experience over the past 2.5 years in terms of their all-cause readmissions performance. The red line is the standard, and the blue line is the actual Providence performance. Actually, the red line would be the expected readmission rate. So what you can see is over time there has been a small and subtle, but it is a decline in the readmission rate. The point of emphasis here is that it does take a multifaceted strategy. It takes resources, and it's something that's not going to happen overnight. It's a journey that does take an investment. Next slide, please. So again, given that this readmissions and reducing the readmission rate is a complex issue, like any challenge, we recommend a stepwise approach and getting started with something that is feasible and achievable that can have an early win. Next slide, please. So the first aspect of an improvement effort would be building that multidisciplinary team. Care coordinators, social work, pharmacy, nursing leadership, physicians, administrative leaders. Increasingly, your information technology and data management teams are going to be important in this. And then as well, as we move towards patient-centered models of care, capturing the patient experience and use of patient advocates as members of the readmission reduction improvement team that type of perspective needs to be captured. Next slide, please. So in terms of baseline performance and goal setting for the HEN, what CMS has advocated as the sponsors of the HEN is that the readmission comparison would be the 2010 calendar year. Now I know many sites may have started their work on readmissions before that. If you have comparisons and any sort of graphical things that could be shared before 2010 in terms of run charts, that's fine. But again, what we're emphasizing right now, for most sites, 2010 is going to be the comparison year. As Lucy mentioned, the Partnership for Patients has set a very ambitious goal, targeting a 20% reduction in 30-day readmission rates. And again, that's relative to 2010 rate by December 2013. Next slide, please. So we talked about the team that would be built on the hospital side. I think the other crucial aspect of this, as we've mentioned several times now, is the importance of establishing a relationship with community partners. Readmission rates within health systems reflect the presence of effective medical homes, as the impact of a purely hospital-based intervention tends to be very short-term. Now within Baylor, we have seen this. Patients with a medical home in one of our affiliated outpatient practices, and that's called the Health Texas Provider Network, had a 30-day readmission rate that was almost a third less versus the system-wide rate of patients who did not have medical homes. So again, I know there are many different types of environments that the connection to primary care can be challenging. But however that is, whatever status your particular system is at, I would say making that linkage will have some significant benefits in terms of reducing the readmission rate. Next slide. Looking at the dynamics of the community partnership in a little bit more detail. So primary care providers, that can occur in terms of the individual patient level. So that would be something as simple as trying to enhance access in the community to primary care, helping helping inpatients to facilitate appointment scheduling. I think the next phase that you'd want to look at is managing groups of patients and a population health strategy. That would be for a more advanced step. But what you'd be looking at there would be identifying groups of patients based on risk levels and then having tailored management strategies. Again, for those who are just starting out, working at the individual patient level is what we would recommend. In terms of working with extended care facilities, skilled nursing facilities, or LTACs, home health providers, community health workers, and home nursing, again, there are different models and resources in those areas. This is to note that the focus of our HEN is for interventions that can be designed on the hospital side. And just to note that there are other CMS initiatives in development that would be outside of the HEN program that would have, we would be working on the relationships with some of the other out-of-hospital providers. Next slide, please. I think the other key element of a hospital readmissions program is a good mechanism for information exchange. In an ideal world, we would have a fully integrated health system with a universal EHR, and we could get information sent back and forth between multiple providers that would be timely and accurate. I think we all know that that right now is still not a reality in terms of the environment we all work in. In lieu of that, what many systems have instituted is some type of summary document that has essential patient information. So this would be something like diagnoses, medication lists, allergies, subspecialists, any pending tests. That can be done via an electronic portal. There are also some good paper-based tools that are out there. The last slide of the presentation is an appendix. It is from SHM's Project Boost and shows you an example that they used in their particular program. The guiding principle here is that in terms of reducing readmissions, this key information about the patient really needs to be broadly accessible across care delivery sites. I think one of the tensions we have is the concept of information security and Hipaa regulations. and that's always going to be a tricky balance. Again, in terms of reducing readmission rates, it's access to accurate information that is going to help move the needle. Next slide, please. The other thing we would recommend, due to the complexity of readmissions and the fact that it requires multiple levers, is that you might want to begin your program with a small subgroup. So you could identify a high utilization population or a specific hospital unit that would be aligned with your system's operational goals. An example of that would be congestive heart failure patients, or many hospitals have a geriatrics unit. Just by the epidemiology of those two groups, we know that they're at higher risk for readmission, so they would be a good subgroup for an initial focus. We would then suggest deploying an intervention, targeting that subgroup as a pilot. And when you think of that, given the budget pressures that all of our systems are under, we know that there aren't several $1 million and 10 FTEs coming down the line to help us with these readmission strategies. So it is likely going to require reallocation of your existing resources. One example would be care coordinators. Currently, many care coordinators spend much of their time, they have to deal with utilization review, insurance companies. If there'd be any way to free that person up to actually focus more on the true care coordination and the patient education, that's one example of how you might reallocate the resources. Pharmacy, specialized nurse practitioners, all of those are other examples of how you might redeploy the personnel that you already have in these efforts. The other thing that we recommend, and this is more of a problem in larger systems that have multiple hospitals, but it can even happen within hospitals, is to survey your system and individual hospital for any overlap efforts. Looking across Baylor, we found that there were 25 different readmission reduction programs among our hospitals, and some of those had overlap. There were differences in designs. Again, what you want to do for efficiency purposes, you want to try and align and coordinate those efforts. And you want to share the findings of your local pilots. Successes, failures, and lessons learned are all very useful in terms of driving improvement. Next slide, please. This here is an example of a subgroup pilot study that we did at one of our community hospitals, Baylor Garland Hospital. And the work was done by Dr. Stauffer, who spoke earlier, and some of our Baylor colleagues. And I won't read the entire abstract, but what I will point out is that this was a nurse practitioner-driven transitional care model based on the Mary Naylor approach for a heart failure transitional care program. What we saw was that patients who received the program had a readmission reduction rate of nearly 50% compared to groups that did not receive the intervention. So again, this is an example of, in a high-risk subgroup, you can get that much higher readmission reduction rate. And one of the challenges as this program develops is you may be able to show that type of high readmission reduction rate in a high-risk population. Across the population, the general hospital population, that 20% readmission reduction rate could be more of a challenge. So again, this is where sort of the interactive learning part of the program, where tracking local hospital experience with these subgroups and trying to gauge realistic readmission reduction rates over specific time frames is going to be particularly useful. I think the other point to note with these pilot studies is that you want to have some allowance for tailoring to local environments and workflow. This particular hospital has about 250 beds. That type of approach would not be particularly effective at our downtown hospital, which has 1,100 beds due to scale issues. And so tailoring it to the local environments is very important. Next slide, please. Now, this is an example. We talked about outcomes metrics and also process metrics. In terms of a performance measure for the care processes associated with reduction in readmission rates, really what you have to look at are the discrete processes that we talked about for the different elements of the care delivery program. So education, medication management, discharge planning, adherence to scheduling of follow-up appointments, was information transferred successfully. This is really what you're getting at when you're looking at a transitional care bundle, and the table shows you an example of something simple that you could do at a site level to track your performance. Now, there are some caveats here. One would need to define what constituted a completed process for those different steps. One of the things is when we developed our HEN, we said that we would have one process measure and one outcome measure for each of our performance areas. For readmissions, the process measure is going to be a little bit more difficult because as currently configured, something like this at most sites would require chart review. You could look at an isolated intervention, i.e. did a patient receive education, and probably get that from electronic data sources. But as we've talked about, those singular interventions are probably not going to have any meaningful impact. So that will be an area of further discussion over the next couple months here, how we're going to quantify our process metric for readmissions. Other notes is that this ultimately could be configurable in an EHR, particularly those EHRs that are mature. Assessing outpatient follow-up will be challenging in those settings that are not integrated with their primary care providers or outpatient providers. If you did have to do this via chart review, I think a random sampling approach would be adequate. If you were to select 10 charts per month, that would probably give you a sense of the trends of performance of these measures. The other nice thing about this sort of a table is that it's amenable to roll-up and presentation in a dashboard format. So you could show this to physicians, and I think it would also be very important to show it at a nursing unit level. Next slide, please. Okay, this is an example of our performance tracking at Baylor. Just a run chart here, and this is the type of dashboarding that we show to our physicians, our administrative leadership, and actually the nursing units also see this. So a quick summary graphic can be particularly useful. Notably, on the right-hand side, we also show the system performance relative to individual hospitals. That always tends to generate a little competition, and it also helps with troubleshooting, trying to identify at individual facilities what may be the reasons for success, what may be some challenges that they're having that could be amenable to intervention. Next slide, please. So in terms of expectations for the HEN members, what we are asking for is quarterly data sharing and metrics reporting on readmissions. We originally delivered this webinar in early July, so we had more time at that standpoint, but just given the time pressure and the ambitious goals set by Medicare, we're requesting that we have this first round of baseline metrics submitted by the end of July. Again, what we're looking for are baseline data for calendar year 2010 and the first quarter of 2012. The metrics that we are advocating are an all-cause, all-payer metric, then a readmission metric for those patients over 65 with Medicare, then also a subgroup metric looking at CHF patients. And again, the rationale behind that is that you're looking at different populations. The readmission rates are going to be different. This is going to help inform the national dialogue on what reasonable expectation rates for the performance improvement is going to be. All of the metrics referenced there have been endorsed by the NQM, by the National Quality Forum. Details of those metrics can be found on our website, including the specifications that you would be able to turn over to one of your programmers. Instructions on how to submit the data for those metrics will be forthcoming soon. The other expectation is that you would deploy your reduction interventions and be willing to participate in collaborative learning with the use of the HEN resources. Next slide, please. A bit more about metrics. Again, this is still a sort of a controversial area. I think the parameters of the ideal metrics surrounding readmissions are evolving. Many hospital systems have challenged the concept of the all-cause, all-payer read metric. Multiple viewpoints, and including the CMS rationale for why they think the all-cause, all-payer metric is a good one, are available in the NQF materials posted on the HEN website. We also recognize the need for a broadly feasible and meaningful process measure as well as a balance measure. So if we're looking at readmission rates and we're trying to drive those down, are you seeing changes in length of stay? Are there more emergency department visits? Are more patients being converted to 23-hour observation? So as the program develops and continues, those will be additional things that we're going to be looking at. Of note, we will continue to provide more depth to the process and balance measures, and we will establish those for our HEN by September of 2012. And ultimately, those metrics are going to become part of the quarterly reports. Next slide, please. So in terms of what you could do tomorrow, I'm sure you're all familiar that the Affordable Care Act requires the establishment of a hospital readmissions reduction program with an associated financial lever that can be applied by CMS. CMS has calculated excess readmission ratios for acute MI, CHF, and pneumonia, which will determine payment adjustment for hospitals, and those will be reported on Hospital Compare. Up until yesterday, you had the ability to, and I'm sure many have already looked at these, to look at the hospital reports on QualityNet, and the web link is there. If you go to the hospital's inpatient section tab, then click on readmissions reductions, you can find those readmission rates that will be published in the fall of this year. Next slide. So some final thoughts. Reducing preventable readmissions has been prioritized as a patient safety and healthcare quality issue and will have implications on hospital reimbursement. Evidence indicates that multifaceted approaches crossing care delivery sites, particularly those that entail some form of medical home, and I can't emphasize that point enough, are the most effective types of interventions. And lastly, an adaptable improvement approach with a team of invested interdisciplinary stakeholders, goal setting, and systematic performance measurement and reporting will be required to move the needle. Okay, next slide. We have a bit of closeout material. This is our HEN Readmissions Task Force, and since I'm doing this call from Texas, we're here to help. This is actually the inaugural class of Texas Rangers, special slide from the heart of Texas today. Next slide. We also wanted to point out some of our resources for the Hospital Engagement Network. We will have subject matter experts, including myself, Dr. Stauffer, and others from across our core partners who will be willing to provide consultation and implementation advice. We will talk about affinity group calls here shortly, and then there are also other tools on our handlearner.org website, a literature review, references to Project Boost and Project Red, the metric definitions, and then the CMS methodology for the excess readmission ratio. Next slide, please. So, importantly, we do realize that readmissions are complex, and we're not going to solve this problem in one webinar. We view this as a starting point. As we have for the other areas, there will be affinity group calls for readmissions. And these affinity group calls will be monthly discussions via phone for troubleshooting and exchange of best practices. We will make subject matter experts from the different HEN sites available to participate in these calls. And in terms of what we're going to be looking at first, I would say clarifying the readmission metrics is going to be a priority. After that, the calls will focus on the HEN's needs as indicated by feedback from the participating hospitals. And I believe we are working on a final schedule for those affinity group calls, but there will be one for readmissions in August. Next slide, please. This slide here is a link to our resources, and it gives you the HEN Learner website. Lynette Savage, I want to thank her for her help. She's with Providence Health and Services, and the project manager for their engagement. Gina Geringer is the Baylor project manager for the HEN, and can also be contacted as a resource. And then Amy Ann Withrich, she is coordinating the technical and website aspects of the project. And that's my last slide. Lucy, do you have any closing comments?
This is Jason. I want to thank everybody for participating in the webinar today, and especially thank Dr. Masica and Dr. Stauffer for presenting the information. It doesn't look like we're going to have time for any Q&As, but if you had posted a question, we'll note those and make sure to get back with you. And always feel free to post any additional questions or email any additional questions to us at admin@handlearner.org, or you can contact us via the website. And then also, as Dr. Masica mentioned, that those questions and ongoing conversation will take place during the Affinity calls that are going to start next month. So I'd like to thank everybody again for joining the webinar and hope everybody has a great day. Thank you.
Thank you, Jason.